I was extremely interested this morning to hear a number of talks in environment, biodiversity, and also economics, which raised issues very similar to what I think health science and in particular epidemiology raises in terms of some disconnect between the data, the evidence, and the interpretation, the report from the media, the interpretation, and then the consequences in terms of regulatory actions, etc. So I will try to address some general issues in terms of what is epidemiology and how, which sort of issues one should try to consider when interpreting the results, and then I will go, as Mr. Bousquet just said, a little bit more into detail on reviewing the evidence available on pesticide and cancer from human studies. Obviously, epidemiology is only one part of the data on health effect of chemicals in particular that have to be taken into account when somebody wants to consider the possible impact in terms of of exposure in terms of regulatory actions, etc. But it is an important one, and it is often the part of the data that is more easily misunderstood, misinterpreted, to some extent because of the very nature of the discipline of epidemiology. And I will discuss these issues taking some examples of some of the projects that I've been involved over the years. So epidemiology is, as you see here, very broadly defined as studying health-related conditions in human populations. So it's different from clinical medicine because the unit of observation in the population is not the individual patient. So it's not so much what is happening in the individual, but what happens in groups of populations. And health-related conditions is a very broad definition, and in fact it covers everything from possible risk factors, determinants of disease, genetic factors, to disease itself, to consequences of health interventions, etc., very broad. There are basically two ways to do epidemiology. One is what is called descriptive epidemiology, which consists only in comparing disease or risk factors in different populations to see where cancer is more common, without trying to go into the detail of what is happening in individual levels, whether people who are exposed to a certain risk factor have an increased risk of disease or not. And this second approach is part of what is called etiologic or analytic epidemiology. So basically, if we concentrate on this second approach, which is what really we are interested in when we want to interpret, say, studies on pesticide and cancer of pesticide and other diseases, what epidemiology does is basically comparing two main dimensions. One is disease, who has developed or who is at risk of developing disease and who is not, and exposure, who has been or is exposed or whatever to one or the other factors. And there are two ways to do it, as it is described here. One is a retrospective approach in which patients with the disease, subjects that have already developed the disease, are compared with a group of individuals without disease. And in that case, their exposure status is assessed retrospectively. We go to a hospital, we get cases of cancer or Parkinson or whatever, we get a comparable group of non-diseased individuals, and we try to understand who among them was exposed up to last year, up to 5 years ago, up to yesterday, whatever, to one or the other risk factor of interest. The other approach is what is called prospective investigation, in which individuals who are exposed are followed over time, and a similar group of people who are not exposed are followed over time prospectively. And in this case, the comparison is made between exposure in a way is assessed up front at the beginning, and then the comparison is made prospectively across time. And the nutshell of epidemiology is the estimate of the statistical association between the two factors, between exposure and disease. See whether those who are exposed have more frequently disease than those who are exposed, although in the prospective number 2, or those with the disease were more frequently exposed in the past, in approach number 1. The key assumption, however, is that all this is done in an observational setting. We cannot force people to be exposed. We cannot give exposure to people experimentally as with, say, in an experimental setting like a clinical trial with a drug or with animals in an animal experiment. We have to observe those who happen to be exposed and those who happen to develop disease. So the key assumption is that all the other factors are equal between the groups that are compared, as it is in experimental setting. And obviously this is not the case, unfortunately, in real life. So the key assumption in epidemiology is that except for disease, in case number one, where we could take a group of people with a disease and a group of people without disease, if you remember, or except for exposure, in example number two, we take a group of, say, farmers and a group of people who are not involved in handling any pesticide or whatever. All the other characteristics are similar between the two groups. And as I said, this is not true, except in the rare cases when we can do randomization, like patients in a clinical trial, but this is obviously not the case when we want to study health effect of pesticides or other chemicals. And at least we can collect some information on the other characteristics. Maybe the group of people exposed is older, maybe they live in a rural setting versus the urban setting, whether maybe they smoke more, maybe they have a different diet. I mean, all these other characteristics that may differ between the groups that are compared. So if we can collect good information on these other characteristics, we can take them into account, at least to some extent, in the statistical analysis. So this is really the key issue in observational epidemiology, in studies for causes of disease, cancer or other disease. So epidemiology leads or has the aim to identify this association between exposure risk factors and disease at population level. Because of the observational nature of the studies, with a small exception of clinical trials, but it's not our interest here, there is a role for what is called systematic error, which is the sort of thing that I described before, that there are other aspects of the two populations that are compared which differs beyond, what we are interested in. And basically we can derive causal inference from observational studies as long as these sources of systematic error can be reasonably excluded. It can never be completely excluded because there is always the possibility that some unmeasured factor is playing some role that we don't know. But in fact, there has been a sort of theory of causality that has developed in the last 40 years that have sort of tried to deal with this issue of making inference with imperfect data, with non-experimental type of data. And obviously this is not only related to evidence from the epidemiology itself, but also links with other lines of evidence. I mean, if you have strong support from biological systems, from experimental systems, this adds to the evidence, etc. This approach has really developed within the framework of the studies on smoking and lung cancer, which was the very first strong association that has been demonstrated in modern epidemiology now, more than 40 years ago. And in fact, the first studies on smoking and lung cancer were published in the early 50s, and by the mid-60s, 64 exactly, there was the first very major sort of attempt to get together the evidence of smoking and lung cancer and try to get some conclusion. And this was done within a panel convened by the US government, which produced this famous Surgeon General, SG stands for Surgeon General Report on Health Effects of Smoking. And this is important because for the first time they spelled out a set of criteria to sort of develop causality or infer causality based on epidemiological studies. And this was based very much on the work of this epidemiologist, Bradford Hill, which has 1 year later published a few papers, that really try to systematize this. And this is very much what is still used today. And these are the criteria that were sort of developed, or guidelines or whatever. So the association has to be strong. So the people who are exposed have to have a much higher risk of the disease compared to those who are not exposed. This exposure needs to precede disease from a temporal viewpoint. There should be consistency in different populations. People who are exposed to the same type of chemical in France, in the US, in South Africa, in Japan, should develop the same risk of disease, may not be exactly the same, there may be other factors playing, but should be consistent of results, should be some biological plausibility. The disease, if the same type of effect are observed in the experimental system, this adds to the credibility, etc. Specificity of cause, dose-response relationship is an important one.